Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamconda.
Hello and welcome to Always On EM. My name is Venk Bellamconda.
And I'm Alex Finch.
We're excited to have you join us today. Today we have one of our special guests today. This is Dr. Ronna Campbell. She's an extraordinary colleague and friend for the entirety of my emergency medicine career. In fact, she's been teaching me since I was a resident in psychiatry many years ago. She has her medical degree from the University of Pittsburgh and also a PhD with a focus in immunology. Over those years, her focus has evolved, and she truly is a world leader in the area of emergency care of anaphylaxis. She's a professor of emergency medicine, currently serves as the Associate Chair of Research in our department, and is author to just under 120 peer-reviewed publications, which is incredible. The overwhelming majority of those focus on anaphylaxis. Her work is highly regarded as she was awarded one of the top 10 best anaphylaxis articles in 2018 by the American College of Allergy, Asthma, and Immunology. She was also awarded as the best author in 2016 in allergy immunology by Up to Date, and has many, many more recognitions. She's a fantastic teacher in these areas of research and anaphylaxis, and we're so excited to have you join us today on the show. Thank you so much, Ronna.
Thank you, Venk. Very excited to be here.
Absolutely. Alex, I think today I'd like to learn about anaphylaxis.
I can't wait to learn more. I think all of the accolades you have mentioned are something that people intuitively just know when they meet Dr. Campbell. She's so knowledgeable. Her depth of knowledge on this topic, but also so many, is unrivaled. And she's also just one of the kindest, most wonderful people I've ever met. It has been a joy to learn from you as a resident and to continue to learn from you on staff. And so thanks for joining us on the show.
Thank you. You guys are too kind.
I do have to disclose, Alex disregards almost everything you tell him, and he just jumps to ECMO for all his anaphylaxis patients.
It's always a good option. That's the way. It's always a good option. But today we're going to talk a little bit about allergic reactions and a specific kind of allergic reaction, focusing a little bit on contrast. What got you interested in this area?
Specifically on contrast reactions?
And how did you find a passion for allergic reactions?
Well, that started actually during residency, and it was rather fortuitous, I would say. My background, I have a PhD in immunology, and then went to medical school after that.
So this was a really quick interest that was transient and no, okay.
Yeah. But then when I was a resident, I was actually working with Wyatt Decker. And we had a case together, an interesting case, and we were talking about that. It wasn't an anaphylaxis case, but he just asked me if I was interested or if I had a research project lined up, and I hadn't. And he mentioned that he was doing a study on anaphylaxis, and I was like, wow, that's like the immunologic emergency, and kind of just took it from there. So he was doing a study, and then as he transitioned to Arizona, I continued on studying anaphylaxis.
That's really incredible. So many of our career passions come from these case studies and residency research projects, and so huge shout out to all the mentors out there.
Absolutely.
Great mentors, like you mentioned. Alex, you had a really trying anaphylaxis case.
I did. I think for a lot of us, anaphylaxis, until a certain point in your career, is something that you see that comes in, and it's somebody who I would say is moderately ill. They're developing a little bit of a rash, seem like they're starting to struggle, and you give them some IM-epi. And it's a pretty gratifying thing to treat in general because somebody really turns around. And then I think anaphylaxis is one of these before and after moments in your career. I think you have suddenly a moment where it's among the scariest things that you've ever seen, and that totally shifts your perspective. Mm-hmm. I had a case a couple of years ago now of an older adult gentleman who had a history of a provoked PE in the past and came in newly hypoxic. He had a moderate well score, got a dimer, and it was elevated. So he needed a CT. I remember that his kidney function was a little borderline, so I kind of looked back. He had had a CT of his abdomen and pelvis a couple of months before, and it seemed like his kidney function had done okay, but I went back and talked to him about potential risks of a CT because of that. I anticipated a call from radiology saying, the creatinine's a little borderline. Have you gone over this with the patient? And so we went back and talked about it. He had remembered the CT of his abdomen and pelvis, went well, and I ordered the CT chest. About, I would say 30 minutes later, the patient had gone over, and it was actually one of my nursing staff got a call. The patient was feeling a little nauseous, and they asked me basically to write for a little Zofran. And I don't know what it was. There's a lot of codes that get called in CT, and you go over and you kind of assess the patient, but this definitely wasn't that. This was just sort of a request for a little Zofran, but something felt wrong. So I walked over to our CT area. I remember walking in, and my patient was completely glossed over. He was cyanotic around the lips and just grunting, wheezing and grunting. He was suddenly incontinent, and looking at him, I thought, this person is about to code in front of me. He had just received his contrast bolus, and they had already given one dose of epi when I walked in the door. We immediately gave another epi, and I had to make a decision. Do I try and run what I perceive to be as an imminent code in this CT tube, or do we pull the ripcord and try and get back to the recess bay? In RED, the recess bay it's a stone's throw from the CT scanner, but you still got to get the patient back on a gurney, get him back in. In my mind, at this point, we had given multiple doses of epi. Things really weren't turning around. I was starting to consider, is this patient going to code? Are they going to need ECMO? And so I made the decision to go back to the recess bay, called an overhead code in our ED. And I remember just thinking, again, this is a moment, a before and after moment for anaphylaxis, because we've given multiple doses of epi, and there's calls, do we want to give the Benadryl? And in my mind, I know we'll talk today a little bit about some of these therapies that don't really help in the moment, but I wasn't turning anything away at this point. Mm-hmm. This patient needed absolutely anything I could muster. Ultimately, I did call the ECMO team. They were at the bedside preparing to cannulate. We were giving fluids, steroids. I also vividly remember just the patient's partner at the bedside and their shock also, because it was this thing that was a fairly routine test that we were doing and that the patient had had before, and there had never been an issue. After intubation and starting multiple pressors, the patient did rebound, and we ultimately didn't have to do ECMO. But it was one of the most intense cases of my career in terms of how quickly things progressed in front of me. Mm-hmm. And I think it'll always be a learning point for me. And that's what I would love to learn more about today is mm-hmm. how does this happen? And is this a common thing?
Well, that's a great question. And I would say it's not a common thing. One place to start is to say that there are different types of immediate or early reactions with contrast. They get kind of broken down into early reactions, which are less than 1 hour, and then delayed reactions, which are after an hour. And the early reactions are broken down into the allergic-like and what's now called type A reactions or side effects. They used to be called physiologic reactions, and those are the times where you get some nausea. It's almost like a vagal reaction. You can get bradycardia, you can get hypertension, you can have arrhythmias. Sometimes, rarely, you can have seizures. But those are more like chemotoxicities or osmotoxicities, but they can happen. They're usually self-limited. They're usually not severe. It can be simple things like flushing, which I think we hear commonly that people feel very flushed with contrast.
And are you saying these are not allergic reactions?
These are not the allergic-like reactions.
Okay.
So when you get into immunology, it gets kind of tricky what's actually allergic or non-allergic. And so they kind of lump those into hypersensitivity reactions, because true allergy like a type 1 hypersensitivity allergic reaction is like what we learned about in medical school, where you have the first exposure, then you develop an IgE antibody. That IgE is on the mast cell, just waiting for that allergen to come along again and then activate the mast cell.
Just waiting for that epic order for the next
Exactly.
CT. Okay.
Right. So that's like the true allergy. But there are also situations where just the contrast itself, without the specific IgE, will activate the mast cell. So it'll give you every single symptom of the true allergic reaction, even though it's not an IgE mediated reaction. And for our purposes, it doesn't matter. It could be severe. And it's either it's basically, it can be anaphylaxis. In the radiology literature, they divide it into, they call it allergic or allergic-like. Because again, for our purposes and for radiology's purposes, it doesn't really matter. It's those mast cells getting activated. It's all those mediators getting poured out into the blood and the body, and all those signs and symptoms that you see with anaphylaxis. So the rash, the flushing, the hypotension, tachycardia, the wheezing, all of those things that are effects from those mediators. Those are the two types of the immediate or early reactions.
You've started to touch on some of the symptoms. When I'm standing there in that moment and I'm trying to rapidly narrow my differential, are there diagnostic criteria to say this is definitely an allergic or allergic-like, and I'm still going to do the same thing?
Mm-hmm. That's a great question. And there are two different sets of diagnostic criteria right now. There's the NIAID/FAN criteria. They've been around for about 20 years now. And then there's some more recent criteria, the WAO, the World Allergy Organization. They came out with some criteria a couple years ago, and they're very similar to I'll just call them the FAN criteria, except there's 2 for the WAO and there's 3 for the FAN criteria. I expect there to be sort of a consolidated set of criteria coming out in the next couple of years. But I think the bottom line is they're very similar. And would it be helpful to go over those?
Absolutely.
Okay. So we'll start with the FAN criteria. There's 3 criteria. When we go through these 3 criteria, the first criteria requires acute onset of symptoms. The second criteria requires a suspected trigger. And the third criteria requires like a known trigger or very highly likely trigger. So with each one, the trigger becomes basically more specific and the symptoms can become less specific. So the first criteria, there is acute onset of symptoms along with some kind of skin or mucosal symptoms. So whether that's a rash or angioedema, those 2 things are required. And then also either respiratory or cardiovascular involvement. And then the second criteria is not just acute onset, but now acute onset, but a likely trigger as well, along with one of the 4 organ systems, meaning of the 4 being skin or mucocutaneous, respiratory, cardiovascular, or GI. So GI wasn't included in the first one, because you can imagine somebody coming in with a rash and vomiting, a child.
Kids getting epi all the time.
Right.
Okay.
That's kind of the progression of the symptoms. And then the third one is like a known trigger, something you know that they're allergic to peanuts, they've are exposed to peanuts, and now all that's really required is hypotension or signs of hypotension. So those are the 3 FAN criteria. So the WAO criteria are very similar to the FAN criteria. The first criteria requires acute onset of symptoms, meaning minutes to several hours, with involvement of the skin or mucosal tissues, and then one of the other 3 organ systems, airway, breathing, or cardiovascular, or GI. And then the second symptom is acute onset of hypotension, bronchospasm, or laryngeal involvement after exposure to a known or highly probable allergen for that patient. So even in the absence of any skin or mucosal symptoms. One caveat there is that for the bronchospasm, it doesn't include inhaled allergens. So there's still room for that could still be like an allergic asthma picture. If someone inhaled something they were allergic to, or they were near a cat or something and started to wheeze, that wouldn't be considered anaphylaxis.
How well do you think these criteria seem to work in clinical practice?
So we did a study on this a few years back, and it was a prospective study, a validation study, and we found that there were 95% sensitive, meaning that 95 out of 100 people with anaphylaxis will meet the criteria. They had a 64% positive predictive value, meaning that 64 out of 100 patients who meet the criteria will have anaphylaxis. So really the bottom line is that they're very sensitive, which is what we want them to be, but you still need to use your clinical judgment. And the WAO criteria, to my knowledge, have not been validated yet.
Is that on your plate to do?
It may be, or if kind of combined set comes out, I might wait for those.
To do that one?
Yeah.
Ronna, before we go into the contrast part of things a little bit further, I'm just reminded, I had some hallway conversations with you where I was really struggling early on about how anaphylaxis to me really had to be these critically ill patients that were in shock or in respiratory distress. But you helped me to reframe my thinking. Do you remember some of those conversations, or can you help our audience with what is anaphylaxis when it's not those patients?
I think it's really important to recognize with anaphylaxis that we don't know when it's going to become very severe, when it's going to progress to that life-threatening reaction. Fortunately, most anaphylaxis is not severe. And most anaphylaxis occurs in the community. Most of the time, people get better. And a lot of times we don't even see them in the emergency department. And that's great. But we don't have good data to say when is somebody going to become severe. And so it's always, when we consider, and I think in medicine, we always consider risks versus benefits. And we know that IM epi is very safe. And so when patients maybe aren't severely ill, but they do have criteria for anaphylaxis, or showing signs of multi-system involvement, it makes sense to treat with epinephrine. And I think that's what the criteria have really helped us with over the last 20 years, is to recognize that anaphylaxis is not just a type of shock. I think we used to think of it as a type of shock. Now we see it as a systemic allergic reaction. And it's important to recognize that you don't need to have shock to have anaphylaxis. You don't need to have a rash or skin symptoms to have anaphylaxis. And you don't have to have severe symptoms to have anaphylaxis. And so in all of those situations, it still makes sense to treat with the IM epinephrine and prevent it from becoming severe or life-threatening.
That's super helpful. Another piece that confuses me at times is, do I need to wait for tryptase for the diagnosis of atopic disease before treating?
Okay. Yeah. So tryptase can be helpful, but more so in the follow-up phase. At least here, we don't get the tryptase results for maybe 6 hours or maybe even the next day. And I think that's the case in most places. I'm not aware of any point of care testing for tryptase. And so it can be helpful in the follow-up phase. The problem with tryptase is it is specific, but it's not very sensitive. So you can have anaphylaxis and the tryptase can stay normal. There have been some studies looking at basically a delta tryptase, similar to how we look at delta troponins, and showing that a small change in the tryptase can also be indicative of anaphylaxis or a systemic reaction. In our clinical practice, it doesn't really help us because it's not going to come back in time.
So just to review, there's two sets of anaphylaxis diagnostic criteria, potentially one, the amalgam that's on the horizon that we're hoping will help further clarify this. Tryptase is not something we need to be waiting for. Our patient doesn't have to be critically ill in front of us to make the diagnosis of anaphylaxis. We don't have to wait for ECMO as a consideration to make the diagnosis.
Definitely.
In fact, we shouldn't be. We should be identifying these patients earlier if possible, and hopefully initiating treatments earlier.
Yes. And one more thing on tryptase. It starts to rise within the first hour. It can be elevated for up to 6 hours or even longer. So if somebody comes in, they have had a reaction, or you treated it, you weren't sure, it can still be very, like I said, very helpful for follow-up, because when they see an allergist and they're hearing the story, and as we all know, it's not always clear, it can still be a helpful test to order for the outpatient follow-up.
That's interesting. So in Alex's case, where we believe the trigger happens in our department, in that case, we're not thinking about tryptase, of course, but if they're not critically ill, should we delay getting a tryptase for an hour?
Oh, I wouldn't say necessarily you have to delay for an hour. Probably by the time you've considered it and you've ordered the labs, it's probably time, because it rises pretty quickly in that first hour.
Okay, perfect. Now, going directly into contrast-induced or contrast-related anaphylaxis, I'm assuming most people listening already intrinsically care. But if somebody doesn't automatically care, what would you tell them? Why should they care about contrast-related anaphylaxis?
I think because even though it's a very rare event, it can be fatal. And as we know, CT scans are on the rise. There was a study that showed in 2019 there were 70 million contrast-enhanced CTs done in the U.S. So if you look at 70 million contrast CTs, and even if fatalities are basically estimated to be 2 to 9 in a million, that's still a significant number of people that could potentially have a fatal reaction. So I think it's very serious, something that's iatrogenic and something we need to be prepared to recognize and treat.
So when we're talking about a contrast allergy, what part of the contrast is the problem? I'm iodine, and then when I was a med student, I learned a little bit about a shellfish issue. And I remember when I was a med student, I would always try and write down for my patient who had an acute PE, how do they feel about shellfish? And in retrospect, that feels like I was wasting a lot of time. What's going on with all this?
That's a really good question, and it brings up, I would say, an important myth in medicine. The first myth being that you can be allergic to iodine, because it's impossible to be allergic to iodine. As we all know, salt is iodinized, and we all need iodine in our bodies for our thyroid to function. So it's a myth, like I said. It's been propagated for many years, and it stems from a study that was done now almost 50 years ago. So this is a study that was published in 1975, and it was a survey study of over 5,000 patients who had contrast reactions. And what they found is that 15% of these patients were also allergic to shellfish. And so they surmised, well, there's iodine in shellfish, there's iodine in contrast, this must be an iodine allergy. So that's where it originated. The thing that's really interesting, though, about these patients is 15% of them were allergic to milk and eggs, and 13% were allergic to fruits. So
nobody went and actually interrogated them with iodine?
No, they just made that correlation and thought there must be some sort of underlying causation at work. But what was really going on is that these patients who had contrast reactions were basically atopic in terms of they just had more allergies, which makes a lot of sense, right? But they put those two things together, and then that became propagated through our medical system, and it still is today. And there was actually a study that looked at how this became propagated, and they looked at actually 6 academic medical centers, and they questioned radiologists and cardiologists and asked if they inquire about a shellfish allergy before they give iodine, and they do, and they pre-medicated for it. And so when the staff are doing that, the fellows pick that up, the residents pick that up, the medical students pick that up, and it just continues to be propagated to this day.
So myth number 1 is shellfish has nothing to do with this.
I would say nothing to do with it, except that you might be just picking up on somebody who is prone to allergies. Yeah.
Okay.
So it does give you a clue,
Yeah.
That maybe they're at a little bit higher risk, because if you have one allergy, you're probably more likely to have other allergies too.
But the same as if they had allergy to eggs.
To milk.
Or milk.
Exactly.
Yeah.
So
Right.
myth number 2 then is iodine. If it's not iodine, what's causing this?
So when you're saying like a contrast allergy, so
Yes.
what's tricky is sometimes when you look in the medical record, it says an iodine allergy. And then you really need to ask the patient, what were you allergic to? because sometimes they were allergic to contrast and somebody put in an iodine allergy. Sometimes they were allergic to betadine and they put in an iodine allergy. Or sometimes they were allergic to seafood and they put in an iodine allergy. So you really don't know when you see an iodine allergy in the chart. There's no way to know what that means. So you have to talk to the patient about it and see what's really going on.
Clinically, when you see a patient that has iodine allergy listed, and you've gone and talked to them and you've discovered that this is actually a betadine reaction, are you adding a comment into the medical record?
I have done that where I talked to the patient about it and I found out that it was not an iodine allergy. And I actually explain all of this to the patient and tell them about the myth that we believe in medicine. And I, as always, talk about risks versus benefits. Like, I don't think you're going to have, because of course that patient could still have a contrast allergy and I just didn't know it. And just have a really frank conversation. I don't think you're allergic to contrast. There's no reason for me to think that. Are you comfortable with me doing this study? And then if I give them do the study and they weren't allergic, I go in there and I modify it to fit whatever the reality is, or completely remove it if it makes sense to completely remove it. So
I will say the allergies tab in Epic is at times very entertaining because it's like an anonymous message board, and there's a lot of people anonymously sharing strong opinions. So the first thing will say like iodine allergy, and then somebody in all caps will write, not the case, received CT. And so there's like a whole trail of anonymous comments. And then I agree, at times, I'm not sure it's really moving me forward. There's just a lot of things to fear there. But I think this does get to some important issues. So if you see a betadine allergy, let's say they put betadine on the patient and it was more than just some local irritation. Is that patient at higher risk for a contrast allergy if I send them over to CT, or is this all nothing?
Again, just that with the caveat that somebody who is prone to allergies might be at a slightly higher risk for any other allergy. Same with anything they're going to be exposed to. But beyond that, no. So what the allergy there with betadine is most likely an allergy to the polymer that the iodine is diluted in or dissolved in. It's called povidone. And you can be truly allergic to that. Like you can definitely have an IgE mediated allergy to that. So when patients have a betadine allergy, they have a betadine allergy, but it's just not to the iodine part of the solution.
Okay. So when I think of contrast, I think of iodinated contrast. That's a lot of times how it shows up. Iodine, I'm learning, is the benign part. It's really everything else. So are there different kinds of contrast?
That's a great question. And I feel like it's something that we in emergency medicine don't learn a lot about. There are lots of different kinds of contrast. For example, the one that we use most commonly is iohexol. It's also known as Omnipaque. There are lots of other types of contrast, and a couple other ones, like trade names are Ultravist and Visipaque. And these different types of contrast, patients can be allergic to one type, but not to the other type. And radiologists can change that up.
I think that actually ties into our clinical story, because I remember as I was starting my resuscitation, I said out loud to the team, this is a very odd scenario because my patient has had CTs in the past and has never had a problem. And on the one hand, that would be somewhat characteristic of an allergic reaction, that you would have one as an exposure, and then it's really the second one. But then I remember somebody in the room saying, this was a different kind of contrast. We looked back and this is a different kind of contrast. And that would really speak to the point that you're making, which is that when we're saying iodinated contrast, there's a sea of options there. And
exactly.
A patient could have a reaction to one and not the other. And so that's so interesting.
So one way to think about contrast might be thinking of it as a class, or in terms of an allergen, like nuts. So someone could be allergic to peanuts, but not walnuts. Same thing, they could be allergic to iohexol, but not a different type of contrast.
That's such a helpful mental model that, I'll be really honest, I've never understood that. To me, this was iodine, and I was looking for the class. I was looking for, hey, it's iodine. If the other one has iodine, that's really the problem. But It's so silly in retrospect when I'm thinking about my thyroid function and things like that. Iodine's not the problem. And I've never had a patient come in and say that they don't want salt in their food. That's for sure.
But again, I think this is a gap in our education, that we learn a lot about all different types of drugs, but we don't very commonly learn about different types of contrast.
Ron, I'd like to transition into the situation where I'm sure you find yourself in a lot. You have a patient that you're worried about, that you'd like to further evaluate them with a contrasted CT. And you feel clinically pretty strong about that. Yet there's a real and not insignificant risk for anaphylaxis based on their history. Take us through how you're approaching that patient, what you're going to talk to them about in terms of the risk of moving forward with that diagnostic image, and any medications or other interventions you're going to do ahead of time to try and make it as safe as possible.
That's a really good question, and very dependent on what the prior reaction was is a very key consideration. So if it looks like it was full-blown anaphylaxis, and I'm pretty convinced of that, I'm going to be very reluctant, of course, to give contrast again. But again, we have to look at the risks and benefits is what it always comes back to. And having that discussion with the patient, something along the lines of abdominal pain, but I have low suspicion for something severe, or maybe I think that a non-contrast CT will get me the information that I really need. Taking into consideration the severity of the reaction that they previously had and the severity of what they're presenting with, or what the life threat is that I'm dealing with. So those two things, of course, come into play. If I really feel that I do need to give contrast, I'm going to try to do a different type of contrast than what they had in the past, if at all possible. And that's going to require a conversation with the radiologist. Before proceeding with that, of course, I'm going to have that risk-benefit shared decision-making discussion with the family with the patient or the family, to try to be sure that we're all understanding those risks. But then I'm going to talk with the radiologist to try to, if possible, figure out what kind of contrast they had in the past to prevent that. There's actually a really good study that was done where they looked at patients who had prior contrast reactions, and this was kind of a variety of reactions. But when they looked for the rate of recurrent reactions, just for all comers, it was actually only around 25%. So most of those patients didn't have a recurrent reaction. And then when they compared that to when they did do pre-medication, that rate dropped down to 17%. And when they switched the contrast type, it dropped down to 5%. So basically 95% did not have a recurrent reaction when the contrast type was switched. So that's going to be important. When they added pre-medication to a contrast change, that dropped down to 2.7%. But that wasn't a statistically significant difference. But I think the real take-home message is if you can change the contrast type, that's where you're going to get your biggest bang for your buck. Would I give pre-medication in that situation? I probably would if I had really serious concern, knowing that I'm probably medicating myself more than I am the patient, to be honest, in terms of what it's really going to do. But I think at that point, if I'm truly concerned, I'm going to try to do everything I can to mitigate a reaction if it does occur, or prevent one if possible.
Pre-medication is something we talk about a lot. You mentioned weighing risks and benefits. Are there downsides to pre-medication?
One of the big downsides of pre-medication, if you want to do the full pre-medication regimen, is the delay in diagnosis. So the standard or long protocol is the steroids 12 hours and 2 hours before, and then the antihistamine an hour before. And I'm sure different institutions have different protocols for that. But you could be delaying a potentially serious diagnosis. I think that's really key. Prolonged length of stay, either in the emergency department or the hospital. Of course, increased costs, increased risk of hyperglycemia, and then a theoretical increased risk of infection with steroids. So there are downsides to be considered.
Let's take the other scenario. You have a patient who gets the contrast. You were unexpecting, and they come back with a reaction, not in a code like the case that we've discovered with Alex, but they are meeting criteria for anaphylaxis. Take us through your approach for medications you're giving. I'm assuming it centers around epinephrine, but how are you approaching that
if they do meet criteria for anaphylaxis, I'm going to start with the epinephrine, with the IM epinephrine.
So even if they have an IV, you're giving intramuscular epinephrine.
Exactly, because it's much safer. So we've actually studied this here, and other people have studied in other emergency department settings too. And whenever you're giving IV epinephrine, you have an increased risk of arrhythmias, ischemia, cardiac ischemia. But the biggest risk is giving the wrong dose. So it's complicated, as we all know, with epinephrine. There's you're giving a small dose, like 0.1 milligrams, or it's first easy to tell the nurse the wrong dose, but sometimes that can be missed in translation. It's been very well documented that there's a high risk of giving the wrong dose when it's been, especially with a bolus of IV epinephrine, and a much greater risk of cardiovascular side effects.
If you have to give repeat doses, are you also giving them intramuscularly?
I typically am for about at least 2 or 3 doses, depending on how severe their hypotension is. If that's the main issue, depends on what's really going on, of course. But yeah, I would probably do at least 3 doses IM, but typically that can be dosed every 5 minutes or more frequently if needed. And it's probably going to take that long anyway, just to get the IV. If you're going to start a drip, to get that ready, you're going to be obviously giving fluids at the same time, albuterol, whatever it is. If you're worried about their airway, you're going to be moving in that direction as well. So usually there's time for at least 2 or 3 doses before you're ready for the next ones.
In Alex's case, he mentioned that people were talking about steroids and antihistamines. Take us through where the current literature is and your approach to those adjunct medications in the case of anaphylaxis.
So the current literature definitely stresses that epinephrine is your treatment of choice, and that you don't want to delay the epinephrine while you're giving steroids or antihistamines. There really isn't good data to support the use of steroids and antihistamines. I guess I would say it's controversial at this point, but I think as time has been going on, there seems to be less and less data to support it. And so they're definitely considered adjunctive, whereas the epinephrine is the mainstay.
Another medication that I hear come up a lot is famotidine.
Mm-hmm.
Do you ever consider giving that?
Well, it's an antihistamine, and it has been shown to reduce rash. So again, and as an adjunctive therapy, I think it makes sense. Mm-hmm.
When we have a patient who is really sick, given 2 rounds of IM epi, we have the epi drip running, what are other things that we can give?
Great question. So when it comes to epinephrine, I just want to put in a little plug to say that there are situations where a bolus of IV epinephrine is indicated. And these are the cases where you feel that your patient has impending cardiovascular collapse. So this is not just your standard IM treatment. So I would always say do your IM treatment, then switch to your drip and fluids, and then even consider adding another vasopressor. But if your patient is really nearing cardiovascular collapse, that's where the IV bolus might come into play. And it just requires extreme caution to make sure that you're giving the correct dose and accepting the cardiovascular risks of giving IV bolus. But in that case where, again, it's always comes back to that risk versus benefit, where you feel that patient is at risk of impending cardiovascular collapse, where you might give that basically the 0.1 milligram tiny bolus of the epinephrine, trying to prevent that cardiovascular collapse. So I don't want to put that in there, but I, again, really want to caution physicians to be extremely careful in that situation.
Well, it makes sense. One step from there is cardiac arrest, and
Exactly.
we're going to be giving IV epinephrine
Exactly.
anyway.
Right.
Yeah.
So it's when you're moving in that direction, that's going to be your go-to. So you're going to do the IV boluses. But you can, if they're responding to the drip but not quite as well as you want, then you can add other vasopressors. And there's not really good data to say what to add next. I think in the critical care literature, that's probably similar, where you get into these situations where what's the second vasopressor? Is there really good evidence for it? In anaphylaxis, I'm not really aware of good evidence for the second vasopressor, but certainly you can add another vasopressor.
So second pressor is dealer's choice. How about other adjunctive treatments? Is there anything that people generally try and is supported or not supported?
Yeah, so glucagon, again, is another option. Not very well supported, basically supported in terms of case reports. And the mechanism in that it directly activates adenylate cyclase bypassing the beta adrenergic receptor. So the idea is that you're going to get some of the same downstream effects. Maybe you've already saturated your beta receptors and you want to get another mechanism to try to produce the response you're looking for. It's something you can try, but again, not a lot of evidence behind it. And then methylene blue is another thing you've probably heard about. Again, that's something that can also be tried. It's been found to increase systemic vascular resistance in other settings. And so something that can also be tried. Again, these are really extreme cases. And again, not a lot of evidence behind it.
I think that we're missing a really key therapy here, which is the ECMO team. And I want to say that I look at the epi literature with a little bit of skepticism. And I think that we could really implement ECMO for any case of anaphylaxis. And I think that we would support the patient very effectively through that episode of anaphylaxis. What are your thoughts on that, Dr. Campbell?
If only there were no risks with ECMO.
Okay.
I'm glad you brought that up.
In the obs,
Yes. 6-hour obs.
Short course of ECMO.
Yeah.
All kidding aside, a really important emerging therapy. And I think that anaphylaxis is that case where you can save a life. And it can be a young person's life, a young healthy person's life, somebody who 30 seconds prior to eating that peanut, they were living a normal life. I think it's really key, and I'm really thrilled to see all the work that you're doing here to make that therapy available to us. And I know of a single case where a life was saved with ECMO from anaphylaxis, a very severe case. And so I think it's really powerful, and I'm glad to see that becoming more available in more and more emergency departments. And I think the key, again, as with all cases with ECMO, and I think you'd be better to speak to this, is sooner rather than later. Don't wait for that severe acidosis. Don't wait for that anoxic brain injury. Get it going.
Don't wait for the Benadryl.
Right. Don't wait for the Benadryl.
ECMO team, stop. Give the Benadryl. Let's see how this goes.
Exactly. I'm thrilled to see that it is a therapy that is available, and I think it is truly life-saving, and we've seen that in our own shop. So it's a wonderful thing.
One other aspect I'd love to hear the current take on is biphasic reactions, and especially with contrast as a trigger. Where do things stand with that?
I love this question because I feel like this question really speaks to the different levels of expertise. Like when I was an intern, I didn't know how long to keep somebody. And then confidently, when I was starting on staff, I said, this is a 6-hour observation. I 100% know what's going to happen. And then as we started to kind of pick at the edges of that knowledge, I was like, how long should I be watching these patients? Is this a real thing? And then I was left with more questions than answers. So yeah. I'm dying to learn about.
Well, it's a great question. And I agree, like the literature has been changing. And I think the key when it comes to biphasic reactions is they are a real thing, but they're probably not as common as maybe some of the early studies suggested. So the early studies were looking at severe cases of anaphylaxis, and they were finding up to 20% biphasic reactions. But now we know that increased severity is an increased risk of a biphasic reaction. So it makes total sense that the early studies would have found that when they were looking at severe cases. But now as we talked about earlier, are defining anaphylaxis a little differently. We're not waiting for somebody to be in shock before we give them epinephrine. We're treating them sooner. And early epinephrine reduces your risk of a biphasic reaction. So it makes sense that we're seeing lower rates as we're giving more epinephrine and giving it earlier in the course and not waiting for people to get sicker. So those are two things to keep in mind. So basically, as we understand more about the risk factors for biphasic reactions, I think that's what's allowed us to take more of a customized approach to how long should we observe for biphasic reactions. So like we talked about, increased severity is going to increase your risk of a biphasic reaction. Delayed epinephrine is going to increase your risk. Cardiovascular or pulmonary comorbidities, multiple different types of risk factors. So taking into account the patient's risk factors, the particular reaction that they had, how severe it was, what manifestations they had. We also know that most likely the biphasic reaction is going to be similar to the original reaction. So, if they had severe hypotension, then that's certainly higher risk. If they had laryngeal edema, those are going to be patients you're going to want to observe longer or even admit to the hospital. So the bottom line is really we can customize our length of observation for the patient and that reaction. And then, of course, their access to epinephrine and their access to urgent health care. So we can send patients home with epinephrine because we have a 24/7 pharmacy on site, but that's not the case in a lot of places. So they won't be going home with epinephrine. So that needs to be taken into consideration. So all those things come into play in terms of deciding. And I would say in terms of how common are they, what I quote to patients is about 1 in 20 will have a biphasic reaction. And a lot of those reactions aren't going to be severe. But something I always educate patients about and make sure that they have epinephrine when they go home. They know that this is a risk and that they know how to use their epinephrine and come back.
In our ED protocols, we usually watch somebody for about 6 hours from the dose of epi. Is that after the 6 hours, are they good to go, or do they still have to be vigilant?
I think they should still be vigilant. The new definition for biphasic reaction is a reaction occurring between 1 and 48 hours. So I think that's what I would say. There are reactions that can, of course, happen after that, but that's usually what I tell patients is it could happen up to 48 hours. Pretty unlikely, or even very unlikely, but just letting them know so that if they start to notice those symptoms, they're aware of it and they know what to do.
So let's take a patient who had more of a mild reaction, got some epi. We've watched them for a couple of hours with a customized plan. What are the best practices for a safe discharge plan?
It's a great question. The first one, of course, is making sure that they have access to epinephrine and that they know how to use that. So they've been given a prescription, they can get that filled. Someone has demonstrated how to use the auto injector. And by the way, there are things on the horizon where may not be auto injector. So other means of taking epinephrine, whether intranasal, sublingual, different things are out there.
Interesting. And part of this teaching is that giving the epi in the thigh is better than giving it in the thumb. Is that right? That is yes, absolutely. One thing. Well, one way to remember it is blue to the sky, orange to the thigh. But yes, that's definitely a risk with epinephrine, and it's happened many times with auto injectors, even to healthcare providers and pharmacists, and making sure they have epinephrine, that they know how to use it, and then really important to send them to an allergist for follow-up so that they can get additional testing. They can confirm or refute what the allergen was. We did a study on this a number of years back where we found that many of the allergens that we suspected weren't actually the allergens. And also to look for other things. Some patients can have something called mastocytosis. There's a lot of other allergy things out there that we don't really think about, but that's what the allergists are there for. They can continue to prescribe the epinephrine. They can really work out a detailed action plan for the patient or their family. And again, really figuring out what the trigger was and helping them avoid it in the future. So they have a lot to add. You mentioned an action plan. Are there key things that you should discuss in our disposition planning?
Mm-hmm. So, I wish we had a better action plan that was available to us. There are some out there. Some of them are pretty vague, but I think really just letting the patient know if their symptoms are coming back. Anything beyond, I would say, like skin or mucocutaneous symptoms, that it makes sense to give epinephrine and probably be reevaluated. We used to say for patients with epinephrine, if they ever took their epinephrine, that they needed to come into the emergency department. That recommendation is being dialed back a little bit. That came about through COVID when we were trying to reduce visits, but I think it does make a lot of sense. And that's something that really the allergists can get into them. I think from our standpoint, we can tell them, use your epinephrine. If they were here in the emergency department with the reaction severe enough to come to the emergency department, it probably makes sense for them to come back. But I think that recommendation is getting dialed back a little.
Ronna, this has been incredible. Is there any final words that you would leave our audience about anaphylaxis, specifically from contrast?
I think the main things are to understand that there are different types of contrast. Also that you can't be allergic to iodine. And that just because you're allergic to shellfish doesn't mean that you're going to be allergic to iodine. And I think educating the patients about that and educating each other about that, it's really important.
I certainly am. Thank you.
This was incredible.
Thank you.
Fantastic.
Thank you so much. I really appreciate it.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamconda.